DG is a 40-year-old female complaining of nausea, reddish-brown emesis, and shortness of breath. She was admitted to the ICU from the ER for a GI bleed. She attributes her weight gain to apathetic mood and fatigue. She has limited transportation, and she has not visited her primary care physician in over 5 years. She smokes 1 pack of cigarettes per day for the last 15 years, or since she was age 15, and drinks 1 pint of whiskey every single day, and denies illicit drug use. She is unemployed, has difficulty keeping a job, and she lives with her boyfriend and has no children. DG's inpatient medications include normal saline 1 liter, octreotide 25 milligrams IV, ondansetron 4 milligram IV, folic acid 1 milligram by mouth daily, pantoprazole 8 milligram per hour IV, nicotine patch 7 milligrams daily, as well as chlorodiazepoxide 25 milligrams. At home, she takes 2 tablets of Motrin daily. Her current vitals are BP 99/71, heart rate 73, creatinine clearance 30.9 mils per minute, BMI 35.9, which indicates she's obese. Her lab results, she has elevated chloride, BUN, serum creatinine, white blood cell count, hematocrit, platelets, AST, ALTs were elevated as well at 109, 67, 2.2, 13.8, 30.2, 152, and 67 respectively. Her bicarb, phosphorus, albumin, urine sodium were low at 20.6, 2.3, 2.4, 1.6 respectively. For the physical exam, the patient appears older than her stated age. Her breathing is slightly labored. She has a large distended, tense abdomen with positive shifting dullness and fluid wave. She has mild hepatosplenomegaly. She has the positive Babinski signs as well as the positive asterixis, the flapping tremors. She has a positive spider angioma on her neck and a 1+ generalized edema in the lower extremities. She's slightly confused and drowsy. Her MELD score is a 27. Her Child-Pugh score is Class C. And her abdominal ultrasound shows a marked ascites, a suspicion for hepatic cirrhosis due to the nodular contour of the organ.
For end-stage liver disease with cirrhotic complication, the goal of therapy is to prolong survival rate. Primary intervention is liver transplant. For variceal bleeding due to a bout of emesis, goal of therapy is to reduce the risk of bleeding, decrease the nausea and vomiting, HVPG of less than 12, and improve quality of life. Initiate Nadolol 20 milligrams once daily to slow the progression of small varices to large varices. Titrate dose every 2 to 3 days to maximize the tolerant dose of a heart rate of 55 to 60 beats per minute. Treatment should be continued indefinitely. We want to monitor the heart rate, blood pressure, and the chances of angina. Initiate octreotide 50 mics IV bolus, then 50 mics per hour to decrease bleeding events. This dose should be continued for 3 to 5 days. Monitor thyroid function, blood glucose, and ECGs. For acute kidney injury, suspected HRS, the goal of therapy is reversal of the renal failure symptoms and prolonged survival until transplant. DC the normal saline. In addition to the octreotide, initiate albumin 64 grams IV daily to decrease the large volume paracentesis and provide rapid symptomatic relief. Discontinue after 14 days if there's no response. Monitor serum creatinine, hematocrit, and hemoglobin levels as well as electrolytes. Initiate norepinephrine 0.5 milligrams per hour IV continuous infusion to activate the RAS and the sympathetic system. Decrease after 14 days if no response. We want to monitor for CVP, BPH. For the ascites, the goal of therapy is to prevent SBP, decrease abdominal discomfort, and increase respiratory function. We want to educate the patient to avoid NSAIDs, so the Motrin that she's currently taking at home, and restrict diet for the sodium to 2 grams daily. Initiate spironolactone 100 milligrams and furosemide 50 milligrams to decrease the fluid retention. Titrate dose every 3 to 5 days based on the fluid volume. Maximum dose of spironolactone and furosemide is 400 milligrams and 160 milligrams respectively. Monitor potassium level, EKG, and hepatic encephalopathy, as well as renal failure. Initiate cefotaximine 1 gram IV Q8 hours to prevent SBP. Continue therapy for 7 days or until cultures are back. We want to monitor for superinfections, adverse reactions, as well as the cultures. For anemia and thrombocytopenia, goal of therapy is to reverse the anemia and thrombocytopenia events. We recommend IV iron levels be drawn. Medication therapy is not recommended at this point, but anemia and thrombocytopenia will be assessed post-banding procedure. For smoking cessation, the goal of therapy is to decrease the cravings, increase smoking cessation, and improve quality of life. We want to switch nicotine patch, the 7 milligrams to 21 milligrams, to aid the patient with her cravings. We want to monitor the heart rate, blood pressure, as well as the patient's craving. Upon discharge, we will educate the patient about alcohol and smoking cessation